So next question states, there is a 44-year-old lady who is an interior decorator. She had her mastectomy done along with the axillary node clearance. Post-operatively, she develops arm getting fatigued while painting the walls, which is the most likely explanation for this clinical picture. So that is the damage to the thoracodorsal nerve. Now thoracodorsal nerve is supplying the latissimus dorsi, and latissimus dorsi is the muscle which is frequently involved in repetitive arm movement, which involves arm being elevated and moving up and down, especially for the painting. Alright, so they have given you a very good clinical scenario with a typical clinical picture, and they have asked you to identify that which of the nerve was damaged. So as you could appreciate from this diagram, so thoracodorsal nerve, artery and vein, they are present in this area, which is the area for the axillary node clearance, and this is going to be the clinical picture for that. We know that if there is a loss of sensations from the axilla and the medial aspect of the arm, then it will be the intercostobrachial nerve. If there is involvement of the long thoracic nerve, then we will be having serratus anterior, and for the latissimus dorsi, we have the spinal accessory nerve. So they can give you different scenarios and they can ask you different questions related to this area. So 10-year-old boy fall and had deformity and swelling of the forearm. Now he has difficulty in flexing the fingers of the affected limb. However, there is no sensory impairment. Imaging shows displaced forearm fracture, which nerve is being involved. So with flexion, you can think of either median nerve or the ulnar nerve, alright? Because these are the two nerves which are responsible for this. But they have clearly mentioned that there is no sensory impairment. So we can easily remove ulnar nerve. Now, with specifications to median nerve, there is only one branch, that is the anterior antroceus, that only has motor implication. So I have mentioned this before. Try to focus on the statement because there are reference points which can help you identify or pinpoint your right answer. As you could appreciate from this diagram, that median nerve is going to divide into anterior antroceus and a deep branch. Now, this anterior antroceus nerve is going to supply the deep muscles of the forearm, which includes flexor pollicis longus, the lateral half of the flexor digitorum profundus, and pronator quadratus. So these are the muscles which are responsible for the pincer movement, and this is the area, that is the proximal area of the forearm, which gets fractured or damaged. Then this will be the clinical picture for the AIN nerve injury. So which nerve is responsible for innervation of the tricep muscle? We have the radial nerve. So here we have the best mnemonic, which I have revised a couple of times. So now we will be revising the reflexes. So S1, S2 is for the ankle reflex, L3, L4 is for the knee reflex, C5 and C6 is for the biceps, C7 and C8 is for the triceps. So next question states, there is a 17-year-old man. He had difficulty using his left hand. It has been a persistent problem since he sustained a distal humerus fracture as a child, and there is a diminished sensations overlying the hypothenar eminence and the medial 1.5 fingers. We know that this is the hypothenar eminence and this is the middle 1.5 fingers, and we can easily check for the ulnar nerve. So 35-year-old laborer, he had an injury on the posterior aspect of his hand and he severs some of the extensor tendons. So they're asking that how many tunnels lie in the extensor retinaculum, and the answer is 6. So we have 6 compartments over here. So I will label them in their respective compartments so that it can be asked that in compartment number 4 which muscle is present, which is present in compartment number 2, right? So abductor pollicis longus is present in the first compartment in addition to the extensor pollicis brevis. In the second compartment, we have the extensor carpi, radialis, brevis, and longus tendons. In the third compartment, which is this muscle, which is turning down like this, rotating like this, that is present in the third, that is the extensor pollicis longus. Now, in the fourth compartment, we have two muscles. Now, these four tendons are of the extensor digitorum, and along with that, we have the extensor indicis tendon. Now, extensor digiti minimi is present in the fifth compartment, and extensor carpi alaris is present in the sixth compartment. So, which nerve supplies the sensations of the nail bed of the index finger? So, we have this diagram which is showing the nail bed involvement on the dorsal aspect, and we have only one nerve, that is the median nerve. So, 58-year-old lady who had a mass in the upper outer quadrant of the right breast. Which statement related to the breast is not true? So, we have to select the false statement. That would be nipple refraction may occur as a result of tumor infiltration of the clavipectoral fascia, because actually nipple retraction and skin dimpling are the key features of breast malignancy. When the parenchyma of the breast gets involved, then these two features are apparent. So they occur as a result of the tumor infiltration of the breast ligaments and the ducts, and they will clinically present in the form of breast swelling, discharge, and dimpling in association with other features. Now, clavipectoral fascia is a fascia which encases the axillary contents, specifically the axillary. So, the lymphatic drainage of the breast is to the axilla and also to the internal mammary chain. The breast is well vascularized, and the internal mammary artery branch from the second part of subclavian artery is the main arterial supply of the breast tissue. So, next question states that a 48-year-old lady had an axillary node clearance for breast cancer. Which structure is most likely to be encountered during the axillary dissection? So, we have the thoracodorsal trunk. Now, there is an important concept with the breast cancer. Post-operatively or during the same setting, we sometimes have to take or think of the latissimus dorsi flap. So, they are testing your knowledge with reference to that, because thoracodorsal nerve is present over here, and it is going to supply the latissimus dorsi. Now, latissimus dorsi is later on required for the flap. So, they are testing you with that reference knowledge, that thoracodorsal trunk, which is found in close relationship to the axillary nodes in the axilla, if it gets damaged, it can compromise the function and blood supply of latissimus dorsi, which can later on will be insignificant for the flap for the reconstructive procedure. So, a 78-year-old man is lifting a heavy object. When he feels pain in his forearm and is unable to continue, he has a swelling over his upper forearm. An MRI scan shows a small cuff of tendon still attached to the radial tuberosity. So, which muscle they are talking about? They are talking about the bicep brachii muscle, which has got rupture. So, we know that the short head arises from the coracoid process, and the long head of the bicep arises from the supraglenoid tubercle, and it inserts on the radial tuberosity on the radius, and it is supplied by the musculocutaneous nerve. So, a 6-year-old supracondylar fracture of the distal humerus, and he got his radial nerve injured. So, they're asking that what is the relationship of radial nerve to the humerus in the distal humerus? So, we have anterolateral rotation relationship. So, as you could appreciate from this diagram, axillary nerve is related to the surgical neck and it is present posteriorly, whereas radial nerve in the middle portion is present in the radial groove, and again it is present posteriorly. However, in the distal aspect or the supracondylar or the epicondylar area, the radial nerve is anterolateral in the lateral condylaria, whereas ulnar nerve is related posteromedially to the medial epicondyle of the humerus. So all these relationships are very important. So next up we have a motorcyclist who undergoes an RTA and developed a complex humeral shaft fracture, which got treated with the plating. Post-operatively, he has inability to extend his fingers. So which nerve is being affected? Radial nerve. So we have discussed this mnemonic previously, so you can revise this mnemonic. So when the brachial plexus is injured in the axilla as a result of a crutch palsy, which nerve is most likely affected? So we have the radial nerve. The other name for this is the Saturday night palsy. What happens is in the axilla. Now, when the radial nerve is damaged or compressed in the axilla, I have explained that the elbow extension as well as extension at the wrist both will be absent. So patient will be having a wrist drop, and that is the area where if a patient is using any crutch or he got any injury in this position, then this nerve is going to be damaged and it is going to have wrist drop. So next question states that which muscle is not a component of the rotator cuff? We know that we have deltoid as not component of this because teres minor, infra, supraspinatus and subscapularis muscles are the muscles which are present in the rotator cuff. So either you can remember it with the test mnemonic or you can remember it as a SITS mnemonic, SITS. So we know that supraspinatus arises from the supraspinatus fossa and inserts on the greater tubercle. Infraspinatus arises from the infraspinatus fossa and inserts on the greater tubercle. Teres minor arises from the lateral border of the scapula and inserts on the greater tubercle. Subscapularis arises anteriorly from the subscapular fossa and inserts on the lesser tubercle. So which vessel provides the greatest contribution to arterial supply of the breast? We have discussed this before, that is the internal mammary artery. Now there are some minor contributions which is from the external mammary and the lateral thoracic artery. Now lateral thoracic artery is again branch from the second part of the axillary artery. So an 18-year-old man has severe spreading sepsis of the hand. The palm is explored surgically and the flexor digiti minimi brevis muscle is mobilized to facilitate drainage of the infection. Which structure is not closely related to this muscle? So we could appreciate that the flexor digiti minimi brevis along with the abductor digiti minimi are present in the hypothenar area. Now, hypothenar is the group of muscles which are present on the medial aspect. So we need to know that here ulnar nerve and ulnar artery will be in close relationship to this muscle. However, median nerve which is going to be present over here and going to supply this area will be not closely related. So median nerve will be at a distant side. However, ulnar nerve and ulnar artery are going to be in close association with the flexor digiti minimi brevis. So the first root of the brachial plexus arises from, we have the C5. So it starts from C5, continues as C6, C7, C8 and ends at the T1. So a 23-year-old man had fight and laceration to the posterior aspect of the right arm. There is a problem 2 cm proximal to the ollipronone process and he is having unable to extend his elbow. So which tendon is involved? We know that tricep is inserted on the ollipronone if there is a laceration or involvement of around 2 cm above ollipronone, which is this area, then tricep muscle is going to be affected. So which muscle inserts on the lesser tuberosity of the humerus? We have the subscapularis, which is the muscle which arises from the anterior aspect of the humerus as well. So it arises from the subscapular fossa, that is on the anterior aspect, and it inserts on the lesser tubercle or lesser tuberosity of the humerus. And as it is present on the anterior aspect, it will be pulling the arm inward and its function is medially rotating the arm. So next we have a 22-year-old man who got laceration on the posterior aspect of the wrist, and laceration is found to be transversely oriented and overlies the region of extensor retinaculum which is intact. So which structure is least likely to be injured? So here they are testing your knowledge that which of the structures, which of the options are the structure which is present underneath the extensor retinaculum. So any of the tendons which are present in the extensor compartment beneath the extensor retinaculum are going to be the answer. So above the extensor retinaculum, only skin, subcutaneous tissue and cutaneous vessels are present, whereas all the tendons of these 6 compartments, they are present beneath the extensor retinaculum. So if it is intact, all the tendons will be intact. So our answer could be tendon of the extensor indicis.